Hello, hello, hello everyone. I'm Dr. P, a board certified OB-GYN, and today we're talking about, is endometriosis hormonal? We're going to start our conversation today by talking about what exactly is endometriosis. We will talk about the key hormone in a female that causes endometriosis, and we'll talk about the treatment options. So let's really talk today. All right, so what exactly is endometriosis? Endometriosis, if you ask me outside of the medical world, is by definition a very difficult condition to treat and control. But medically, that's not exactly what it is, right? I just know from treating patients, I know of the stress, the distress, the frustrations that surround endometriosis. And so my heart pours out to you if you have this condition and if you're dealing with it. And so by definition, on the inside of your uterus, we have 3 different layers to our uterus. This is our not so happy endometriosis plush. Our uterus has 3 different layers. We have the endometrium, which is on the inside space. This is where your periods come from, bleeding comes from. This is where pregnancies develop. Deep to that is a muscle layer. That's the intramuscular area. And then on the outer parts of the uterus, I think of this as like the skin of your uterus. And it's the subserosal area, or the serosa. And so it's the covering. And so endometriosis means that the tissue that's on the most inner part of your uterus, the tissue that is located on the internal side, the endometrium, similar tissue to that is also found in your abdominal space. By your abdominal space, I mean the space in your abdomen that holds your liver and your stomach, your bowels, your kidneys, the bladder, your ovaries, your uterus, all of the things. So it's the space that houses all of these organs. And so imagine that the tissue, or similar tissue to that which is inside of your uterus, is now everywhere else inside of your abdomen. That means that when you have your menstrual cycles, you may have severe pain, you may have a lot of activity and inflammation and burning and just pain and generalized inside of your abdomen. And this is what makes endometriosis so difficult, but so painful at the same time. This is not regular cramping. This is, I've taken Motrin and Midol, I've taken naproxen, I've tried all the things, and I'm finishing a bottle every menstrual cycle because I'm in so much pain. I can't work, I can't walk, no sexual activity. My quality of life is through the window. It is no good. I am in distress. That is endometriosis. Now, when we think about endometriosis and whether or not this is hormonal, there's a lot of research that says it is. And I'll explain exactly how it is. Endometriosis responds to your hormonal signals. Whenever we have this tissue elsewhere in our bodies, we call those implants. So we call that endometriosis implants. Sometimes you could also have like a cyst on your ovary, and that is called an endometrioma. And essentially I consider it to be period blood collected in a cyst on your ovary. And so that is like an overview of what the endometriosis picture may look like for you. Now, as you ovulate and the egg dies after 18 to 24 hours, there was no sperm, there was no fertilization, egg dies. That, I'm going to say, death process leads to your uterus getting a hormonal signal to have a bleed, to shed, to remove the tissue that was built up waiting for a fertilized egg. And so that's what causes your periods to come. With endometriosis, regardless of where the tissue that lies inside of the uterus is found inside of your body, it responds to the hormones to create a period just the same. So imagine this. If these are some of the implants of endometriosis and your uterus gets the signal to have a period, these implants say, I'm going to bleed. And I'm going to bleed because my hormones are telling me to bleed. And so you're having these additional inflammatory period-like changes every single menstrual period wherever these implants are inside. And so most commonly they're found on the fallopian tube and the ovaries, but they could be on their bowels. They could be on your abdominal wall. It could be on your liver, on your stomach. It could be in so many different places. Now, the primary hormone that endometriosis responds to is estrogen. It is the key driver here. Endometriosis is considered to be the estrogen-dependent condition. Very, very different from other things like PCOS, for instance. But nonetheless, it is a hormonal condition just the same. So if you're in a state of estrogen dominance, where you have an overpowering amount of estrogens, the likelihood is that you can increase the activity of any lesions or implants that you may have anywhere in your system. This is also why sometimes, depending on treatment options, we often don't prescribe progesterone types of treatments first, because we know that this is an estrogen-dependent type of disease. Now, some of the older therapies, they're still effective, but older therapies that we have would be first to put your system in a non-estrogen active phase. Essentially, this means that we put your body through menopause when you are not in menopause yet. We shut down your estrogens and quiet the activity of endometriosis because it loves estrogens. Now, it works so effectively, but the problem is that we're not able to give you this treatment long term. This is something that you can use for a few months at a time. It quiets everything, but then when you stop the treatment, the activity may return. And so you may have the same amount of pain and discomfort when you're going through your cycles. And so it is not a very good long-term treatment plan. What also happens during this treatment is that you get all the other symptoms of menopause. So you get the hot flashes, which nobody likes those, but you may also have like bone loss, where your bones become less and less dense, and so the likelihood of you getting fractures and all the things increases. The symptoms are not necessarily always as great as the benefits in this case. And so those are pretty tough, but there are more recent treatment options that are medications that can be given more safely to help with endometriosis and the pain related to them. And so the side effects of these medicines can sometimes not be worth the benefits that you can get from them, and then considering that they're temporary, may not be worth it. Hormonal IUDs are also something that we can consider. Hormonal IUDs are progesterone only, and so these are like second or third line therapies, not entirely the primary or the first line. We may also want to consider surgical management. Now, in general, I can tell you from just clinical experience as well as what the evidence has shown, it is often better to excise or remove these lesions rather than ablating them. So ablating essentially means that we're burning them. The remnants of their presence will remain until your body removes, hopefully all of them. But sometimes we can have some inflammatory response that still happens even though an ablation has occurred. In general, excisions are best. The problem with endometriosis, though, is that sometimes it requires multiple different surgeries, and each time we can excise and that comes with its own risks as well, but it just becomes so difficult to manage. Nobody wants 4 or 5 surgeries. Nobody wants to deal with this constantly their whole life, and so it just adds to the challenge. So is endometriosis hormonal? Not entirely. It responds to hormones. It loves estrogens. It's estrogen dependent. It responds to the other hormones of our system, but it is really a multifactorial type of condition. There's so many different aspects to it. We know it's being caused not by your hormones, but likely because of retrograde menstruation. That means your actual period is exiting through your fallopian tubes into your abdomen. And so while that's hormone driven, it doesn't necessarily cause the dysfunction that's happening here. And so I hope that makes sense. Know that if you have endometriosis, there is some light in the tunnel. And the way that we find that light is to talk to your providers, share your symptoms, make notes of them if necessary, have deep conversations with an endometriosis specific GYN that can give you all the options and go through this journey with you. And so I encourage that you find one or talk to your OB-GYN about this. I hope this information has been helpful. And listen, there's another video that I think will be very helpful in your hormonal journey, especially with endometriosis. And I think it will be very helpful. So click the link in the description, come over to the next video, and let's watch and talk and learn together as we navigate this hormonal life together. Thank you so much for being here. Thank you so much for listening. I'm Dr. Perkins again. Take care.